Before we get into kidney donation, let's just start with the basics. Like who might need a kidney and why?
So people who need a kidney transplant are people who have injuries to the kidney that are not reversible and have progressed to the point that they are approaching the need of or are on something called dialysis therapy. And dialysis is really a machine attempt to replicate some of the function that our kidneys do for us to help keep us alive. So as somebody's kidneys are failing or have failed, that's the time when they should be looked at to see if they could benefit from a kidney transplant.
Based on what I've heard, dialysis can be pretty tough on the body. Is that something that a person would try to avoid and get a kidney first? Or what are your thoughts on that?
Yeah, dialysis has two faces. The one is that it's wonderful and it's life-saving. Without dialysis, somebody with no kidney function would die within days to weeks. And with dialysis, people can live for years. So that's the plus side of it. The downside is that, yes, it is not good replacement of kidney function. It's sort of the bare minimum. And because it is not your own kidneys doing their job 24/7, it's intermittent cleaning of the blood and getting rid of the extra fluids and toxins that would normally be gotten rid of by the kidneys. It's harsh on the body. So absolutely an important goal to minimize the amount of time somebody is on dialysis or to avoid it completely with kidney transplants. But that's not to say that if you're on dialysis, you should do as little as possible, because dialysis needs to be done enough to at least keep somebody alive and as healthy as possible.
Right. And so if somebody is on the kidney transplant list, they are in need of that kidney.
That's right. You can't get on a kidney list well in advance of needing the kidney, like you have 50% kidney function. Well, let me get my name in a list in case in 10 years I need a kidney. That's not how it works.
At this point of your life, there's a good chance you might know someone with kidney disease. Maybe you know someone who's needed a kidney transplant, or maybe you even know someone who has made the decision to donate their own kidney to a loved one, friend, or stranger. March is National Kidney Month. Last week, I introduced you to Carrie Kirkland, a living kidney donor who not only made that incredibly courageous decision to donate her kidney to an acquaintance, but who just last week climbed Mount Kilimanjaro to spread awareness, reaching the summit on World Kidney Day. This week is the second episode in our two-part series. I speak with Dr. Martha Pavlakis, the medical director of kidney and pancreas transplantation at Beth Israel Deaconess Medical Center in Boston, and associate professor of medicine at Harvard Medical School. In just 1 hour of your life, Dr. Pavlakis will help you understand kidney transplants and donations in a whole new way. And she takes on some very common myths about the process that people continue to spread every day. This is the Grown-Ass Woman's Guide. I'm your host, Jackie McDougall. Who might be a good candidate to donate a kidney? Like, can anybody donate a kidney?
To get on the kidney transplant list, you have to go through a complex evaluation to make sure that the transplant will benefit you and not harm you. And similarly, if somebody wants to be considered as a kidney donor, they also have to go through an evaluation to make sure that they're not being exposed to extra harm by becoming a kidney donor. So I would say at the outset, if you said, can anybody be a kidney donor? The answer is no. And I could tell you a few parameters that would make somebody not a donor. For example, you have to be an adult. So children are almost universally not considered as acceptable organ donors. You have to be in reasonably good health, and how that's defined, of course, is the important point. But anybody who's an adult and in reasonably good health could be considered as a potential kidney donor, yes. And that's a living donor. It's a very different conversation if we're talking about deceased donation, which is when something catastrophic happens to somebody and they're brain dead or approaching what's called cardiac death, and the family agrees to donate their organs on behalf of society. That's a separate issue. So we're just talking about living donation right now.
Yeah. Right. So in talking about living donation, how many people are waiting for a kidney, and are they differentiating between a deceased or a living donor?
So the kidney transplant waiting list, I don't have the exact number, but it's approaching about 100,000 people. So let's say 100,000 people in this country, about, are waiting for a kidney transplant. That list is specifically waiting for a deceased donor kidney. Now, anybody waiting for a deceased donor kidney could potentially bypass that wait and get a living donor kidney if they had a live donor. Now, in this country, there are more deceased donor kidney transplants done than living donor kidney transplants. But the better operation for almost anybody is a live donor kidney rather than the prolonged wait for a deceased donor kidney.
So there are people who are on the transplant list and that wait is for a deceased kidney, but there are ways
Correct.
to be connected with a living donor. Can we talk about the different ways that one might donate a kidney? Like, I know there's direct donation. Can you talk about that a little bit?
Absolutely. So direct donation is what people think about when they think about kidney donation. So you hear about a loved one, maybe a sibling, maybe your child or a dear friend who needs a kidney. So first you have to know that that person needs a kidney. And then you have to think, well, maybe I could be a donor. I'm willing. And then that person then gets tested, evaluated, and either told, yes, you can donate, or no, you cannot because of some health condition or some factor in your life. So that's direct donation. There is also paired donation, which is when you've been approved to donate to somebody that you care about, but because of some incompatibility between you and the person you want to give a kidney to, you can't give them a kidney directly. They're a candidate for a kidney, you're a candidate to donate, but your kidney will not do well in that person. You can sign up for what's called a pair donation, where as a pair, you go into a database and another pair comes along that has a similar problem, but in fact, your kidney couldn't go into that other recipient and your loved one can get a kidney from that other person's donor. So that's a swap. And then the final idea is somebody can volunteer to donate in what we call, in its most pure form, altruistic donation. In some sense, all donation is altruistic. But you can be a non-directed donor, and that's the better term, non-directed donor, where people present to the transplant center in their region or the organ procurement organization, and they say, I would like to donate a kidney to somebody. I've heard about kidney disease. I've heard about the need for kidneys. This is something I would like to do. I do a lot of altruistic work. I donate blood. I volunteer at the Salvation Army. I do all these things, and I would like to meaningfully help somebody else in this way. And those non-directed donors then don't have an identified person to donate to. And they're used in one of two ways. One is a person at the top of the deceased donor wait list gets the call that you're paired with this live donor who will give you a kidney. Another thing they can do is donate into a paired algorithm where they start a transplant and then they start a chain of paired transplants. It gets a little complicated without a board to write it out on, but
right.
So that, I even get mixed up as I'm talking about it unless I can write it down.
Can you talk a little bit about the voucher program? Is that a thing where you donate? I'm going to use my own circumstances. So when my son, he's 17 years old, was said that he was going to need to get on the kidney transplant list, I was like, Mom, so I'm doing it. I'll give him my kidney.
I'm doing it, right.
Yeah, like I brought him into this world. I'll give him my kidney. It was a no-brainer for me. It was absolutely 100%. That's what I was going to do if they would allow it. And then I got a call recently, and they said, I'm 51 years old and he's 17 and it's not ideal.
Right.
And so I've heard things about the voucher program where as if I were to donate a kidney to someone who is maybe more age appropriate, that he then or family members would get some voucher to put them at the top of the list. Is that true?
Right. So that operates there's a number of private nonprofit organizations which facilitate kidney swaps. And I believe the voucher program, and I may be misspeaking, I believe it's something available only through NKR, the National Kidney Registry is what that stands for. They've got a kidney registry voucher program, which allows a living kidney donor to choose the most convenient time frame for their donation. And they get provided a voucher to people who can then be prioritized to receive a living donor through the NKR when that person is ready. So that sort of separates in time the donation from the person needing. And then the person needing the kidney would get prioritized to get a living donor kidney from somebody else through these swap programs. Okay. So I have not participated in NKR, so I can't speak to it more than that. There's also a kidney pair donation program through the OPTN administered by UNOS, the United Network for Organ Sharing, and that's called
Right.
KPD, Kidney Pair Donation. And I believe
Mhm.
that does not have a voucher program, but the NKR does.
So there's the kidney pairing that could happen right at your center with other people. And then there's like other organizations that are outside of these centers that can also kind of
Right.
come in. Okay.
Facilitate, right. And your
Yes.
transplant center may or may not participate in these other programs. The KPD, the UNOS
Oh.
program, which is national, I think everybody participates in because it's part of being a transplant center and you don't pay extra. Kidney transplant centers sometimes opt to pay extra to be part of these other swap programs because it leads to more kidney transplants, which is a financial benefit to the hospital.
Once in a while, Dr. Pavlaka sees an altruistic donor, also known as a non-directed donor, come into the transplant center, interested in donating a kidney even without an intended recipient in mind.
Non-directed donor is somebody who comes forward to donate without a pre-identified person who's going to get their kidney.
Okay. And how often do you see non-directed donors? I don't know if you have the numbers.
I don't have a number. I can say not often. I would say pre-pandemic, we probably evaluated at my institution maybe 0 to 2 people a year. So it's not a common phenomenon. And then they have to go through a similar workup. So a very important point anytime we're talking about living donation is that the willingness to donate one of your kidneys is necessary, but not enough to be accepted as a live donor. So you can be as willing as you
Right.
want, but if you have diabetes and you're on insulin and you are at risk of kidney injury to yourself in the future, no transplant program is going to accept you as a donor. So willingness is important.
Right.
It's the start, but it is not the end of the donor evaluation process.
So what are the guidelines for someone like you or me to donate? One might assume that to donate a kidney, you have to have a body fat of 15% and be a marathon runner. And that's also not the case, right?
That is absolutely not true, because in my career, I deal more with kidney recipients than donors, although I've done both for my entire career. And often people who need a kidney will say things like, my brother wants to donate, but he's not been to a doctor in years. And so who knows? Like, I don't think he'll be able to donate because I don't know if he's healthy. Or I know somebody, but she used to party pretty hard when she was younger. So you don't take people who smoked and did drugs, do you? The question is, how healthy are they now and what risk are they at for the donation?
Right.
So there are a lot of misconceptions about who can be a donor.
Yeah. And I'm really excited to bust some of those myths today. So thank you for doing that. Donating a kidney can be a long, arduous process filled with many steps and lots of twists and turns. Today, my goal is to simplify that information so you walk away from this episode feeling informed and empowered. What does the evaluation look like? Like, what is the first step if someone's like, I would be interested in finding out if I could donate? What would they do?
Donate, right. Ideally, the first step is that the person sees their primary care doctor and gets up to date on their routine cancer screening. So if you are a woman and you're of age to get mammograms or your annual pap smear and they haven't been done, they're going to need to be done. Now, it doesn't have to be the first step, but it's absolutely necessary to have all your routine cancer screening. We have had people step forward to donate who have said no to getting any colon cancer screening because it doesn't sound nice. They don't want to do the prep. And we tell them, we're not going to force you to get colon cancer screening, but you can't donate a kidney until you've gone through all your standard American Cancer Society recommended screenings. So that doesn't have to be the first step, but that's what I would recommend to anybody wanting to get evaluated. The first step really fundamentally is contacting the transplant hospital where the person you want to donate to is listed. And there is always, if they're a transplant center, they're going to have a donor team within their transplant team. And that you would probably have contact with a nurse coordinator on the donor team who would either electronically or on the phone go through a series of questions with you. And the questions are really meant to, at the very basic level, screen out people who absolutely cannot donate. Like I mentioned, you have type 1 diabetes, you're on insulin. They're going to say, thank you very much, but we're not going to go any further. That's the end of your evaluation. If you pass that series of questions, then different centers have different protocols, but at our center, you actually come in and meet with a nephrologist, you meet with the nurse coordinator, You get a series of very basic measurements like your height, weight, and your blood pressure, and you get an educational session. And you also meet up with somebody called an ILDA, Independent Live Donor Advocate. This is somebody to sort of be your partner in the process, outside of the people determining whether or not you can donate, to help be sure that you are actually understanding the risks and benefits, that you're not being somehow pressured into donating, and that you are making this decision of your free will, that sort of thing. So as you go through the process, you not only get evaluated as to whether or not donation is right for you, but you also get evaluated to make sure that this is really in your best interests and that you're not feeling pressure or responding to pressure to donate. The transplant community is very concerned with the idea of subtle or even overt coercion, where somebody is made to feel guilty into donating or is being coerced through financial incentives. For instance, if you want to donate a kidney to your employer, that will raise a lot of red flags, is that somehow are you being required to do this in order to keep your job? So those protections are part of the evaluation process and are very important. One of the prime objectives of a donor team is to protect the interests of the donor. And that is why there is really a separate donor team. Back when I first started in transplant, you could easily be evaluated to be a donor by the same doctor that is taking care of the person who needs the kidney. And if the doctor taking care of the person who needs the kidney is very invested in that patient and very aligned with that patient, it's possible that they would evaluate the potential donor with an eye towards getting the kidney for the patient and not with as much of an eye towards protecting the donor's autonomy and safety and health. So those teams are very separate.
Right. So if someone were to move forward with kidney donation, they know that whatever center they go to has their best interests, like physically, mentally, emotionally.
That's right. And anybody going through a transplant evaluation to donate will tell you that they are asked and reminded numerous times that you can stop the process whenever you want. As you learn about what it means to be a kidney donor, if you change your mind, please let us know. We will support you. We will help you. Sometimes people change their mind and don't know how to tell the person that they had promised their kidney to. And the donor team is there to specifically support the person who wants to pause or halt the evaluation process.
And how do they communicate that to the person waiting for a kidney? Are they like, sorry, your sister's out? Or are they a little more subtle?
We've gotten much better over the years as the awareness of protection of donor autonomy and safety has really been baked into our system, not only educationally, but also from a regulatory standpoint. We are, as transplant centers, we're evaluated to make sure that nobody evaluating the donor is part of the care team for the potential recipient. So it's really set in there. The way that we break the news to people that, hey, you know, quote unquote, your sister is out, is actually at the very start of the process. When we first meet somebody who needs a kidney, we tell them, get the word out, living donation is best. And oh, by the way, you will not find out anything about your live donor's process through the evaluation or their testing results unless the donor tells you themselves. We will not tell you what is going on. And if somebody gets turned down, we will not tell you why they're turned down. And if you want to know what was your sister's kidney function or has your brother done his EKG yet, we won't tell you any of that. So we prepare people at the outset to understand the importance of that confidentiality barrier. Sometimes it's a joke in a way because, say, a husband-wife team, and most likely, you know, the person who needs the kidney is in the room when the person who's being worked up to donate is getting the phone call and getting the feedback. Nonetheless, we tell them, your donor can tell you anything they want, but you won't hear it from us. And so we prepare people like that. We do our best. And then we say, you don't currently have any potential living donors. You know, how else can you get the word out to other people? And people will say, well, what happened to my brother? He said he would call. And we said, we can't give you any information on that.
Right.
So it's gotten better over the years. We've gotten much more clear at the outset with candidates and donors.
Yeah, that makes sense. So let's get back to the process a little bit. So they went for that original day. They talked, they were sort of counseled a bit, met with a nephrologist. And so what happens next?
So next they have to, if they haven't already done the colonoscopy or the mammogram, you know, the routine cancer screening, that has to be done. Then they get a series of tests that are above and beyond testing you would do just as a normal person screening for health. So they get a number of tubes of blood drawn. They do some sort of assessment of kidney function, which at many places involves collecting all the urine that you make for 24 hours. It's 24-hour urine collection. They for sure would get an EKG and a chest x-ray. And then depending on your other risk factors, you might have to go for other tests and other consultations. So somebody of a certain age group, maybe with a history of smoking or a family history of heart disease, might be asked to get a stress test. Somebody else might be asked to see a specialist dermatologist because of a history of skin cancer. So other evaluations might be recommended at the outset or as a result of some of your test results. So it can be, you would think it could be a quick process. And frankly, if all of our healthcare delivery systems were organized around efficiency, which, as you well know, they aren't, the donor could be worked up in a matter of days. But that's not the way our healthcare system works, unfortunately. So the evaluation of the donors tends to take weeks on average at a minimum. And that's if everything goes very smoothly and the donor moves along very quickly. And the donor motivation and time to get this workup done is actually a component in how quickly the evaluation gets done. So we have potential donors who come in and say, absolutely, I want to be worked up to donate to this person. And the nurse coordinator will say, great, we fill out the questionnaire. When can you come in and meet with the team? And they say, well, I'm an accountant. This is my busy season. Then I'm going away. Then I'm going to a wedding. I'll get back to you sometime in June. So all of a sudden, it's like a 4-month delay, which is fine. There's never any rush to donate a kidney because people have dialysis to fall back on. But if that person then in June, the coordinator calls and leaves a message and the person never calls back, then generally the team will just document and stop pursuing them. So sometimes people will start a workup and not complete it. And one of the obligations of the donor team in not pressuring somebody into donate is not pestering them to get their workup done.
Right. Because maybe they change their mind and they just don't want to tell you.
They just don't want to tell you.
Potentially.
And so then the blood tests, the urine tests, the routine cancer screening, the chest x-ray, the EKG, the psychosocial evaluation, these all take time and appointments. And as you know, just logistically speaking, going in and out of maybe a city for appointments means time off of work. It means parking. It means maybe having to arrange elder care or child care that you normally would be providing. So there are out-of-pocket expenses, like I just mentioned, that the donor incurs that aren't covered by the recipient's transplant center and insurance package. For people who have financial insecurity, there are programs to help reimburse some of those expenses. But it's not a trivial amount of time or, in fact, out-of-pocket costs to go through the evaluation process.
So that's a good point. When you are matched with someone, it's actually under the recipient's insurance that all those bills are paid. So that's not necessarily an expense to the donor.
That is the testing specifically for donation. And everyone says it's under the recipient's insurance. Actually, it's not completely. And I'm not an expert at this, but I believe what happens is that the transplant center covers that expense. If the donation happens, then the insurance then pays for the donor. But the workups that are done that do not yield a billable kidney transplant then are covered partially under the Medicare cost report, which is a way that Medicare at the end of the year reimburses hospitals for workup they've done in support of transplantation that didn't end up yielding a transplant. It gets complicated, but the most important point is that the donor's insurance does not pay for the donor workup. And the donor shouldn't have to pay for the donor's workup, except for those costs that I mentioned, driving and taking time off of work, et cetera.
Absolutely. And also, like you mentioned, there are organizations for like lost wages or travel expenses if you had to go to another state to help someone out to donate a kidney. I will link to all of those or to the ones that I've discovered. Being in this process a little bit, I have links to some of those resources, so I'll share those for sure.
Good.
So if someone's going through this workup, I mean, it sounds pretty intense. So they're either going to find out that they're in pretty tip-top shape or how often does somebody discover an issue with their own health while going through this?
Not infrequently. And in fact, that is at the outset of being worked up as a living donor. That is one of the risks of going through the process, is that you may find out news about your own health that you didn't already know. Most people don't see that as a risk. They see that as a benefit. And I can tell you there have been people with cancer diagnosed at an early enough stage where it could be treated immediately and completely. I had one father looking to donate a kidney to his adult daughter, and I evaluated him, and he seemed in tip-top shape. We sent him for one of the final tests, which is a CAT scan, looking at the anatomy and the blood flow to each of his kidneys. And lo and behold, there was a completely silent kidney cancer on one of his kidneys.
Wow.
And it was of a reasonable size. And he actually ended up being ruled out as a donor. You cannot donate. He went to a urologist. He underwent a curative nephrectomy. So they took out the cancerous kidney and it cured him. But of course, he could never donate a kidney because now he only has one. And this young woman's sister actually donated to her. And I saw them afterwards. And actually, the dad had brought his daughter, who got the transplant from his other daughter, into the clinic. So I greeted him and said, I heard what happened and how are you doing? He said, I've recovered completely. He said, and it was an amazing experience. I came into this center hoping to save my daughter's life, and it turns out she saved mine.
That's amazing.
So
that made me emotional.
That's amazing. It was beautiful and a very positive outcome. Now, it's not always a positive outcome. You could find out something from the evaluation about which nothing can be done, and you're learning about it sooner than you would have otherwise. And you could argue that is a detriment to your quality of life. Or you could look like you have something and end up going down the path of getting biopsies and maybe having complications. And it turns out on final report that it wasn't a cancer, and you've been put through the ringer that you normally wouldn't have gone through had you not entered into this donation process. So I don't always count learning more about your health as always a positive thing. Sometimes it can lead to testing and procedures that in retrospect were unnecessary.
That makes sense. So I could hear the listener going, wait, but can you just live with one kidney? Like, is that dangerous? So can you answer that?
I can, yeah. So people are born with two kidneys that generally equally contribute to the cleaning of your blood and the getting rid of excess fluids and toxins. So we depend on two kidneys, but it has long been known that if one kidney is removed in somebody with two healthy kidneys, two things happen. Number one, the amount of kidney function you have is cut in half immediately. But that if you're otherwise healthy, the remaining kidney over the next month starts to work a little harder, gets a touch bigger. It doesn't grow dramatically, but it expands its workload to get you back up to about 75% of normal.
Okay.
And on the scale of percent of kidney function, while 100% is the best and 75% is a little bit less, it's not in the danger of kidney failure. So yes, as long as you have two well-functioning kidneys and you're otherwise healthy, you can absolutely live with just one kidney. There are a few subtleties and caveats to that, but I think at the first level, that's the most important point.
Okay, thank you. And what are those subtleties and caveats? We're going there.
I do. In having redundant organs, we are fortunate that if, like that man who got a kidney cancer on the one side, he had that cancerous kidney removed, and he's going to live the rest of his life with just one kidney. But if you donate a kidney in your 30s, and in your 50s or 60s, you develop a kidney cancer in your one remaining kidney, the surgery to eliminate that cancer will now leave you with probably inadequate kidney function because years ago you had donated one of them. So we don't casually donate one kidney. It's best to keep both your kidneys. We do it because it's a benefit to the person to be helping somebody that they love. But we can never guarantee that in the future, after someone donates a kidney, they won't come to have negative health consequences because of the donation. And the examples are being shot in your one remaining kidney, right? And you have a trauma, stabbed, cancer, destroying that one remaining kidney. Because you donated, you don't have the other one to fall back on. And in acknowledgement of that, that things can happen to people that we can't predict, even with all of our upfront testing. People who have donated a kidney and then themselves come to need a kidney transplant actually get extraordinary priority on the deceased donor kidney transplant list.
Interesting.
Yeah, in recognition of their donation. And this actually applies to donation of any organ. So if you're a partial lung donor or a partial liver donor or a kidney donor, if you end up needing a kidney in the future, you get status as a prior live donor. And that basically puts you ahead of the vast majority of people on the list waiting. So former donors get a lot of priority, kind of jokingly calling it a consolation prize. It's not it's not ideal. It would still be better if we could predict everybody who might go into kidney failure in the future and not take kidneys from them. But our predictions are imperfect, especially when people are donating at younger ages.
Right. And so if somebody were to donate a kidney, let's say in Los Angeles, and then they moved to Texas and they had kidney issues themselves, how does that particular center know that they donated a kidney? Like, is there a network?
There is a network. It's called the Organ Procurement and Transplantation Network. It's OPTN. And every transplant in the country has to be registered with the OPTN. So every single living donor is listed at the OPTN. So the program in Texas doesn't have to get evidence that you donated your organ in California or any place else in the country. If you did donate in the country, then when they put you on the transplant list because you now need a kidney, they check the box prior live donor and the system automatically finds you from when you were a donor. Oh. So you're listed in the OPTN as a former donor forever.
Wow. No matter how many decades are in between.
Right. And it's not state-based. It's not city-based. It's not transplant center-based, which is good because you don't want to have people who've donated organs but lost the paperwork or forgot what hospital it was at. Because healthy people often move states. They don't remember where they got blood work done. It's surprising, really, but people say, oh, it was the hospital on Humboldt Avenue. It closed,
Right.
And so fortunately, you don't need that data. It's already in the network.
Interesting. And so you talk about these transplant centers. I have a two-part question. Number one is, are they all created equal?
So on almost any level that you look, they are not created equally. And in some ways, that's a good thing. In some ways, it's a bad thing. So in terms of it being a good thing, I think that one recipe wouldn't fit all parts of the country or all regions or all urban versus rural localities. I know some transplant centers operate where they're the only transplant center in a very large geographic region. And other transplant centers like my own operate within stone throws of each other. So there are numerous highly qualified kidney transplant centers just within the city limits of Boston. Whereas I know some programs, like I said, they're the only kidney transplant program in the state. So they can't all operate equally because their environments are so different on that note. However, the important point, and I think this is really a downside, unfortunately, is that kidney transplant programs can vary dramatically or meaningfully in their criteria to accept donors and recipients. So if you want to donate a kidney and you go to one center and you have a history of a kidney stone 15 years ago, at one center you might be told, we don't accept people with history of kidney stones, goodbye. Whereas at another center, like at my center, we'd say, it's just one kidney stone. It happened years ago. We're going to do a special stone test on your urine. And if you look like you're a stone former, we're not going to take you. But if you look like that was a one and done, which a lot of times kidney stones are, just happens once and it never happens again. And we advise you to stay well hydrated and you don't have any of those metabolic problems that would predict that you're going to get more kidney stones, we'll take you as a donor. And the downside of this variation amongst centers is that it's not completely transparent. So when somebody gets turned down at one center because of the history of stones, it's not, I don't think, immediately available to them the fact that if they went to a different center, they might get a different answer.
Right. Is that a good thing? I reached out to some people in a donor group and I said that I was told that my age was not ideal to donate to my son, who's 33 years younger. And they said, well, go to a different center. And part of me was like, oh, maybe I will. But frankly, the outcome for my son is my first priority. And so
Right.
is the age, like at your center, would you advise against a 51-year-old donating to a 17-year-old?
So we don't take care of people younger than 18. So if you
Okay.
just move his age up to
A
19, I can
52-year-old
answer
and an
that
18-year-old. I'll be
Perfect.
52 this
Okay.
year and he'll be 18 this year.
And he'll
And
be
so,
18. Okay.
right. So would you advise against that?
Never. What I would do is I would say, that's great. Thank you for stepping forward. We would love to proceed with you as a donor. However, if there's a more age close, I won't say age appropriate, somebody closer in age who is also volunteering to donate, we would like to start with that other person. But if they get turned down, or if there is nobody in their 20s who wants to donate to him, boy, you're up next. The other thing we might do with that many years difference between the two of you, especially if you were both an easily swappable blood type, let's say you were O and he was A, we might say, okay, you've been approved to donate, he's been approved to receive. Let us look in the swap system to see if we can find a 50-year-old who has a 22-year-old donor, and your kidney could go into the 50-year-old and their donor could go into your son. Now you might say, why would that other person give up their 22-year-old donor?
I was exactly saying that.
Yeah, maybe they're in the swap program because their blood types don't match.
Right.
So the 55-year-old person who needs the kidney is an O, and their donor is an A, and they cannot donate to them. So they go into the swap program, and lo and behold, you and your son come along. You can donate to him, but if you want a younger kidney for him, you can help out that other pair by getting that person a kidney, because right now he can't get from the person who's donating to him or wants to donate to him. And then in return, your son gets a kidney from a younger person. So I would never say you're not ideal. I would say you're wonderful. But let's first look for somebody younger. There is none. Okay, let's second look at your blood types to see if we can swap. And third, if we can't, we would take you, because avoiding dialysis for your son or minimizing his time on dialysis is more important than getting a kidney from somebody who's much younger. I had this exact situation back in the year 2000, 2001, with a mother and her son, just like you. And that kidney has been in that son for over 20 years. I just met with the mom and her son recently, and I would say his kidney is not working super well, but it's still working. And would it be working better if the donor was younger at the time of donation? Potentially, but that doesn't matter. We got him off dialysis very quickly because his mom was a willing and able donor. So I would never turn you away as a potential donor to your son.
Okay. Thank you for that. And so how long does the kidney last? So let's just say that 20-something-year-old got a more age-aligned kidney. Are they expected to live the rest of their life with that kidney?
No. So somebody your son's age is likely to need more than one kidney transplant in his lifetime. It's not a guarantee, but the only way I would say somebody at 18 might have a kidney for many decades, like into his 50s, would be if he got the kidney donation from a same age or close in age sibling who happened to be a very, very tight match on all those proteins important for transplant longevity. So I can tell you from recent data, we term everything in terms of years of survival. So the 10-year survival of live donor kidney transplants done in 2008, so looked at in 2018, was about 65%. That means of transplants done from living donors in 2008, 65% were still working 10 years later. Okay. It's not great.
And what are the reasons that they wouldn't work? Yeah, that seems like a crapshoot a little bit.
It's not ideal. Right. So what we tell people is on average at the outset, when you get your transplant, if it's from a live donor, it should work between 12 to 15 years or more on average. Now, if you get to year 15 and that kidney is still working perfectly, I wouldn't predict it only has one more year. No, I'd say you're one of the people who maybe it's going to last 30 years. Right. Or maybe it's going to last even longer. But there are many reasons that kidneys fail. One is that even though we provide suppression to the immune system with drugs to prevent the body from recognizing that kidney as having come from somebody else, there is a slow, over time, attack on the kidney that happens because of the immune system. That's number one. Number two is that the drugs that we give can, in and of themselves, contribute to high blood pressure, the development of diabetes, and direct kidney damage. So the drugs are great at preventing rejection, but they, over time, sometimes take a toll on the kidney. Number three, sometimes the reason that the person went into kidney failure comes back in the transplant. Sometimes yes, sometimes no. And then taking of these immune suppressants drugs, it's a challenge, both in terms of adhering to the regimen, insurance, financial issues. Things happen that contribute to damage to the transplant because of inadequate immunosuppression. Those are just some of the categories of things that can contribute to kidney damage over time.
Right. Wow. I mean, it's a big damn deal. It's
a big damn deal. Absolutely.
I just have to acknowledge that there for a second. So let's say you have a 25-year-old with a sibling, and that knowing that the kidney probably won't take that 25-year-old through the rest of their lives. Is there any benefit for trying to find a kidney now and holding on to that sibling for the future donation?
Absolutely. So I, at one point years ago, had a situation where I had a man in his late 20s who needed a kidney, and two people stepped forward, his similar age brother and his father, who was in his late 50s. And both passed the workup, and both got into a little bit of a over who was going to donate. The father and the brother both wanted to donate and brought their case before us at a meeting because they didn't like the answer that we gave. And the answer we gave was, let's start with the dad, because this young man will likely need a second kidney, and his brother, let's say the dad's kidney lasts 20 years, the brother will be able to donate, hopefully, at that point, maybe not, but the dad almost certainly would not be able to. So, and that was the decision we gave them, to take what, again, any kidney is a good kidney, but maybe potentially a less good kidney to start with, because he'll likely need another kidney in the future.
Right. Yeah, that makes sense. So let's bust some more myths. What are some things that you hear from people that you're just like, whoa, that is not correct? Not to put you on the spot or anything.
I guess the one that comes up most often for me is, and it kind of breaks my heart, is when people say, oh, I can't have a live donor, I'm adopted, because they think it has to be a blood relative. That's a misperception that a lot of people have. And unfortunately, when I tell that person, no, the person doesn't have to be related to you, they then have to transmit that information back to their friends and non-blood relatives who have already made the assumption that they can't donate, and maybe are comfortable with that assumption and don't want to go back to being able to donate. So that, I think that myth that you have to be a blood relative is probably the number one. If I could wave a magic wand and get rid of any myth, it would be that. The others all fall into the, like, we can tackle this during the process in terms of education, but that is the one I think that really limits people from getting potential donors, because there's this widespread misunderstanding that it has to be a blood relative.
Right. And to that point, do you have to have the same blood type?
So actually, no. That's another thing. People often say, oh, I have a donor, my sister is my same blood type. And I always say, that doesn't mean she's a donor. You know, she's got to go through the whole workup. She's got to be willing to donate. So it's not just like, boom, your blood type matches, you're in. But to the blood type question, because there's this paired donation swap possibility, we tell people blood type doesn't matter at all. If you want to donate to your loved one, if you're blood type compatible, great. You could be a direct donor to them. If you're blood type incompatible, which means that your kidney will be attacked immediately because you're a B and they're an A, then you can donate to another B whose loved one is an A, and they can donate to your loved one. So the swap really sort of eliminates the requirement for blood compatibility. But if you're the kind of person who says, I'm only going to donate my kidney if my kidney goes directly into the person that I care about, then the blood type limitation is that if you are an O, then there's no limitation. You can give to any blood type. That's the universal donor.
Right.
If you're an A, you can give to somebody who's A or AB.
Okay.
If you're B, you can give to somebody who's B or AB.
Mm-hmm.
And if you're AB, you can only give to another AB.
Okay. And if I'm an O, which I am, and I'm a universal donor, and my son is an O, and he's not a universal recipient, he can only receive O.
Precisely. So it's a good thing that you're O. And if you weren't, you guys would be a candidate for the swap. Also, people often ask me, what about A positive versus A negative, O positive, O negative?
Oh, yes.
The pluses and minuses don't matter for kidney transplant.
Okay.
They matter for blood donation, but not for kidney transplant. So we just look at A, B, O, A, B, but not at the positive, negative. So that's the blood type compatibility question.
Right.
There's also something called HLA compatibility. HLA stands for human leukocyte antigen. And it's those other proteins that we talk about that are important for transplant rejection. It is possible that anybody waiting for a kidney, especially if they've been exposed to pregnancy, blood transfusions, or other organ transplants, prior kidneys, they could have in their blood little proteins called antibodies that are targeting other people's HLA types. So let's say I've had 3 children. I got exposed to their proteins throughout pregnancy. I formed antibodies against their proteins. If I, as in my later years, need a kidney and one of my adult children volunteers to donate, they have to do special testing, and they might find that my blood has proteins formed against my son's proteins in his body because of the exposure during pregnancy decades ago.
Interesting.
And then they can't donate to me. So even if we're blood type compatible,
right,
they have to check the kidney recipient or the candidate to receive a kidney's blood to make sure they don't have antibodies targeting other people's proteins. And some people have a lot of these antibodies. Most people don't have any. But that's another case where there could be an incompatibility between people that has nothing to do with blood type.
Right. So on a very random side note, do you ever discover that people are actually related by their testing?
We occasionally discover that they're unrelated.
Oh, so someone thinks they're donating to a relative who is not.
Yeah, this has been written up in the literature. It's called misattributed paternity. And it's when a father steps forward and says, I want to donate a kidney to my kid. And the lab doing all the testing puts down, this is an unrelated donor.
Wow.
This is not this person's father.
Wow.
And
it's like the new Jerry Springer. I mean, it's you are not the father. Oh my goodness.
And there has been a lot written about that. That is a fortunately very rare occurrence. Yeah. But there has been a lot written about it because, as you can imagine, then as the transplant center, you are suddenly burdened with this information that nobody asked for in some sense, right? And that is a conundrum. I'll just leave it there.
Yeah. Wow. That's a lot.
Yeah.
And so if someone were listening right now and you had 5 minutes, because I know I've taken so much of your time, to share with them, what are the most important things? What's the takeaway of this episode?
I would say the major points of this episode for your not casual listener, but for the listener wanting to learn more about kidney donation would be number one, kidney donation. It's a wonderful gift, but it comes with its own risks, which we haven't even gotten into really. And that the first risk really is the entire evaluation process, which can be time consuming, can involve some out-of-pocket expenses and some medical testing. But that you don't have to be a blood relative to the person who needs the kidney. You don't even have to be blood type compatible because of the opportunity to swap kidneys. And that it is something every step of the way that you need to be comfortable with proceeding, and that there are safeguards in place to prevent people from donating who don't want to, or who are ambivalent, or who really are being coerced or pressured into donating. I think those are the most important points.
Right. One thing I didn't ask that I was curious about too is if a young woman, it was a 25-year-old woman, wanted to donate, can she get pregnant after that? Can she have children? Is there a danger there?
The answer is yes, yes, and maybe. So there is No impact on fertility that I've ever seen for having one kidney because you've donated. So getting pregnant should not be at all an issue related to donation. There are some issues with going through pregnancy and delivering with just one kidney that I think the obstetrics team would observe this person a little more carefully. Not to say that it's a dangerous added danger to be just one kidney, but there is some suggestion in the literature that women who have just one kidney are at a little higher risk for an unfortunately common condition called preeclampsia. I don't know if you've heard of this. It's also called toxemia of pregnancy. It's a complication late in pregnancy that puts both the woman and the baby at quite a high risk. And the only way to prevent it from progressing to a fatal condition for both is to emergently deliver the baby. That
Right.
happens. It happens, I think, not uncommonly in women where they start to show preeclampsia and they have to be induced and deliver the baby quickly. And there is some suggestion in the literature that that, unfortunately, rather common condition maybe is a little bit higher, a little bit more frequent if you have just one kidney, or that it persists in multiple pregnancies, whereas in people with two kidneys, otherwise healthy, that risk is highest in the first pregnancy and then goes down. So I would not counsel a woman away from donating if she then subsequently wanted to have kids, but that would be part of the process to understand that the pregnancy might be at a slightly higher risk of complications.
Right. That makes sense. I mean, none of this is without risk, and just to listen to this and to still say, I still want to go forward. I mean, there are 100,000 people out there who need that.
Who need kidneys. Absolutely.
Yeah. And so I definitely would never suggest to someone that you should just go donate a kidney like there's nothing. And at the same time, would you say that most or many or how many kidney donors go on and live a long and healthy life?
The vast majority. Studies looking in the past at people who donated their kidneys versus people that didn't actually showed that people who donated their kidneys lived longer than the general population. Well, that's a meaningless result, of course, because people who donate their kidneys were tested and found to be super healthy. So that doesn't. Subsequent studies basically showed that they lived about the same, and other studies actually suggested there was a tiny increase in kidney failure, especially if they donated to somebody they were related to. I mean, tiny increase in subsequent kidney failure, but it's not zero. So it really is it's a beautiful gift, but it's not one without risk. And we always counsel people, if you want a risk-free way to help your loved one, you could be their advocate. You could be their driver after the transplant when they are not feeling well enough to come to the hospital. You can provide them meals until they're back on their feet again. Like, there's other ways to help people who need kidneys rather than going through a surgical procedure, which, again, there's no surgery that you have that doesn't involve a small but real risk of death.
Right.
Including kidney donation. Now it's very small. It's about 3 in 10,000, but it's not zero. So it's something to be considered.
Yeah. And do you have a minute to talk about some of the risks of kidney donation?
Sure. Okay, absolutely.
Great.
Yeah. Of people surveyed a year after they've donated kidneys, the vast majority are glad or very glad that they did it. The few percent of people who are not are largely people who there were complications, either for the person who got the kidney or for themselves. There are very few things that we can do that are as impactful in an altruistic way for other people as kidney donation. So many people who donate a kidney really come away from it with a new realization or a appreciation for themselves as giving people in the world. So it can have all sorts of benefits, but there's other ways to get that feel-good benefit that don't involve risk. Once you come in for the operation, the risk of death surrounding the transplant procedure and in the days and weeks after is about 3 in 10,000. That's much less than many other surgical procedures, but as I said, it's not zero. And all those other surgical procedures were weighing against the risk of not having the surgery, which obviously you need a surgery, right? You need that gallbladder out. You need that inflamed appendix out, right? There are very few surgeries, I can't think of any, that you absolutely don't need for yourself. So that 3 in 10,000 risk of death is not being weighed against the risk of death if you don't do the operation.
Right.
The donor is in the hospital for 1 to 2 days until they can manage the pain with oral pain medicines. They've passed gas, their stomach's working, they can eat without vomiting, they've recovered from anesthesia, and they go home.
Mm-hmm.
Usually they're seen in the clinic afterwards a week later. And while most of them look fine, they don't feel fine. They're still tired. They still are healing. Usually at about a month after the operation, when they come back, they're by and large better, although there are some donors that are afflicted by complications such as a wound infection, a wound hernia, a postoperative complication like a urinary infection. Very rare, but again, not zero. And there are some donors who have a prolonged and sort of inexplicable fatigue for weeks to months after donation. These have all been written about in the medical literature. The fatigue is, I don't have any good explanation for it. I've seen it happen in people who are otherwise psychologically extremely happy with the fact that they donated and yet just don't feel themselves quite yet. They're not anemic, their thyroid is working normally, their kidney function is returned essentially to their baseline, and yet they just don't feel well for a while. So I would never counsel somebody that it's easy, that it's risk-free, or that it's without implications for their health. But by and large, at 1 year after transplant, the vast majority of people feel fine, are right back to their regular social and emotional and physical functioning, and are happy that they did it.
And are you advising these people, do they have to change how they live? Are there certain activities that are advised against?
So there are people who've donated kidneys who return to all sorts of activities, sports, especially if that's your livelihood. You know, that has to be something taken into account. But the activities we advise against are, and it sounds a little facetious, but it's the things that would put you at risk for trauma. So I tell people wear their seatbelts. Don't pick up habits like smoking, cocaine use, you know, things that will harm your kidneys. And it's important to avoid the two main causes of kidney failure in this country are high blood pressure and diabetes. And a very common contributor to those illnesses is obesity. So we do caution people to keep and maintain a healthy body weight to avoid diabetes and high blood pressure if you can. Some people can't avoid them. And that if they develop, they need to be treated very, very seriously and controlled as best as possible to protect the function of that one remaining kidney. But there's no activities I would say, no more downhill skiing for you, or no more basketball for you. And even it would have to be extreme sports before I would say that somebody should avoid those extreme sports.
How does someone who needs a kidney balance the need for privacy with the need for getting the word out? I think about all these people. I think about my son. He doesn't want his mom talking about his health on a podcast. I've gotten permission for it, but it's not ideal. And it's not ideal for a lot of these people to post their health on Facebook looking for a kidney donor. And people are seeing a person publicly asking for help in this way. It's not because they're looking for attention, because a lot of these people would like to have their health private like the rest of us, right?
Of course.
And so how do you advise people who want to just be private, but they need a kidney? Where's the balance in that?
Yeah. I have seen all ends of the spectrum where I will have one person come in for a kidney evaluation and say, I've already put it on Facebook. I've signed up for every social media post. I've created a website called Martha Needs a Kidney, right? I mean, and people are just putting their private data out there to the point that I'm advising them to be careful and reel it in a little bit, because there are unscrupulous people looking to take advantage of someone in need, promising a kidney, stringing you along. I need money to do this or money to do that. And next thing you know, you're being taken advantage of. There are other people who I say, I do the education about live donation. And I say, now, how are you going to get the word out? Who in your circle knows about your kidney disease? And they'll say to me, absolutely nobody. My kids don't know. My siblings don't know. My parents don't know. And I want to keep it that way. I said, well, you're never going to get a living donor kidney if nobody knows you need one.
Right.
So, and those are the two ends of the spectrum. Somebody who is 100% private and somebody who is, in my mind, ridiculously public. And what I try to do is move everyone towards the middle. So I caution the person who's put out their public information like that to be wary of scammers, because we have seen them. And I try to help the person who is so private. I try to come to an understanding of what about having your loved ones know about your medical condition frightens you. What are you protecting? What are the repercussions if the people who love you know that you have this need? And trying to understand that rather than just pushing, you got to tell people, come on, you have to tell them. Why aren't you telling them? Would you feel unsafe if you share this? And sometimes it's a very unrealistic fear, and sometimes it might be a realistic fear. So
right.
It's got to be dealt with on a case-by-case basis.
Yeah.
We have a handout that we give patients in clinic called Living Donation Social Media, which basically provides, like, if you want to put out your call for a kidney on social media, these are the types of things to share. These are the types of things not to share. This is what to be careful of,
It's a delicate balance, and I think
it is.
But you see the people in the news, the local news who are looking or wherever, and it happens for them.
Sometimes it does. Those are the stories that get to the news. And you also wonder, if you have the money to put up a billboard saying you need a blood type B kidney or an A kidney or an O kidney, is that really fair to people who don't have the resources to advertise in that way? It would be nice if there was a surplus of kidneys and that people didn't have to wait. It would also be nice if our healthcare system provided equal access to transplant for everybody, independent of income, but we know that's not the case. And there are all sorts of disparities in access to care that this is one aspect of. Somebody who has the resources and the wherewithal and the tech savvy to find a donor in this way.
Yeah, that's such a good point. I'm coming from a very privileged place to know that if it's not me, that I couldn't help my kid. Like, I have the audience, I have the community, I have 12 siblings, I have 30
Amazing.
plus nieces and nephews. There are a lot of people out there who we're very blessed to have. So my goal with this episode is not to find a kidney donor for my child. My goal with this episode is to help people understand. If you're listening to this and you're like, I'm interested in donating, I know of somebody in my community, great. I'm extremely thrilled that inspires. But mostly it's that if your cousin or your coworker or your friend's kid has to go in and have a kidney transplant, that you just understand the process a little bit more and that you're not spreading the myths that are out there and the misconceptions. And that you're like, no, I actually heard Dr. Pavlakis on the Grown-Ass Woman's Guide. And she said, because the more educated we can be, especially as grown-ass women, like,
Absolutely.
When we're educated, we can share with so many people because we have the courage to step up and say, that's wrong.
I appreciate what you're doing. It's a public service. It's contributing to empathy in the world. And that's a beautiful thing. So thank you.
Oh, thank you so much for doing this. I know I took up a lot of your time. So thank you.
Okay.
Dr. Pavlakis' work is saving lives. That's not debatable. She's written and spoken extensively about kidney and pancreas transplantation and is the current chair of the Organ Procurement and Transplantation Network, OPTN, Kidney Committee. She's also leading a current restorative justice in medicine project to support Black and African American transplant candidates in getting the surgeries they need. In fact, Black people have seen an extended wait time on the kidney transplant list due to an outdated kidney function test that didn't account for differences in race and inaccurately showed their kidney function is not severe enough for transplant. With this project, Black and African American transplant candidates will get credit for more wait time, getting them closer to life-saving surgeries. Thank you so much, Dr. Pavlakis, for educating us today. And thank you for listening. If you have questions, comments, or suggestions, let's connect at grownasswoman.guide on all the social channels, or email me at hello@grownasswoman.guide. Please help spread the word about the Grown-Ass Woman's Guide, share it with a friend, and leave a rating and review on your favorite podcast app. I appreciate the feedback so much. Until next time, remember, you are a grown-ass woman. Act accordingly. Spring has sprung, and with the change of seasons, sometimes comes an increase in vitality. If you're feeling in the mood for a little more personal time, may I suggest Coconu. Coconu is all about providing clean and natural ingredients when you're enjoying your most intimate moments, with or without a partner. Naturally safe products developed by people who are obsessed with quality. Get 15% off with promo code GROWNASS at grownasswoman.guide/Coconu. That's 15% off with promo code GROWNASS at grownasswoman.guide/Kokanoo.